Hey everyone, thank you for joining us for another edition of GBMC's To Your Health here on Facebook Live. I am your host, John Lazaroon. That beat, that was something, right? Felt like we had an earthquake or something. The bass was definitely going on.
Yeah.
Anyway, sorry. So we're going to be talking today about making the decision on whether to take your kid to your pediatrician or a family care physician or to the emergency department, depending on what's going on with them. But I don't know if you guys know this. Approximately 30 million children each year visit a pediatric ED or the emergency department. But we're wondering if that's always the best thing to do. So to give clarity on when we should do it, when we should take our kid to their doctor, or when we should take the kid to the pediatric emergency department, is Dr. Laura Scott.
Hi.
Dr. Scott is the chief of the Peds ED and Inpatient Unit at Greater Baltimore Medical Center. Dr. Scott, thank you for joining us today.
Thanks for having me, John.
We got a lot to get to, so why don't we get the ball rolling, huh?
Okay, I'm ready.
All right, cool. So before we start on the, whether I should take my kid to the Peds ED or whether I should take him to the pediatrician or their primary care doc, talk to me about what is really the primary focus of the Peds ED and yourself as a Peds ED physician.
Yeah, so I think in the pediatric ED, our focus is very much on the child, right? At GBMC, I can speak to our Peds ED is staffed by all pediatricians. So our goal when your child comes in is to quickly, accurately diagnose, treat them, but come at it from a very child-friendly and family-friendly approach. So I think, in terms of thinking about bringing your child to a pediatric ED or an adult ED, when you come into us, we have very much the child in mind.
Okay, cool. So I think what's important, though, is that parents should know that there is a difference, right? There is a difference between a Peds ED and an adult ED, not just in possibly the people that are working in those areas, but also what are some of the, maybe technology or some things that, a Peds ED has as far as treating the younger patient as opposed to an older patient in adult ED. Can you explain that?
Absolutely. So some of the things, when we say that we're really child-focused, we know that it can be very traumatic for people of any age, but especially for children and their families. So we try to tailor everything to take as much of that anxiety and as much of that fear out, right? So technology-wise, we use certain lights to try to get IVs that might make it a little quicker, a little bit faster. We can use different medications to make children a little bit less anxious. But one of the things that I love that we do at GBMC is we have child life specialists, right? So people whose main focus is the child, and not only the child, but also the family, in ways of sort of distraction and help with coming in and getting over that fear. Other technology things that we employ in the Peds ED, so all of our imaging is really tailored down to the age, the size, the weight of the child. We try to make it very appropriate so that we don't do too much. We can use just enough of radiation or whatever we need to do to find out what's going on without overdoing it. So everything is very tailored to the size, the age, the specific problem of the child.
So, we talked about the people that work in the ED, whether it's pediatric or adult, and also about some of the technology you touched upon. But one of the things that I think is also to remember is the anatomy of the patient, right? So, we know that our heart is located in a certain spot, but we also have to remember when you're treating a pediatric patient that their body's not as big as an adult. So some things might be a little bit at a different location than somewhere else. How important is that, especially when you bring your kid into the Peds ED?
Yeah, so I think even more important than sort of the anatomy, and we try really hard not to think about children as just little adults, but also is how do you get to that anatomy, especially when a child is scared, is nervous, doesn't want you to touch them, doesn't even want you to talk to them. It's more the art, actually, of kind of making a child more comfortable so that you can get to all those places where you need to listen to their heart, listen to their lungs, which is hard to do if they're screaming and crying and upset and scared. So I think a lot of it actually is really the technique of how you approach them before you even think about their anatomy or what you're trying to listen to or look for. And then otherwise, we very much in the pediatric world rely on the weight of the child, not just the age. So everything is very specifically tailored to the weight, which is a big issue with the anatomy and figuring out their bodies and treating them differently than adults.
One of the questions that came in is about if you can differentiate on the medical expertise you and your colleagues provide on the Peds side compared to the medical providers in the adult AD. But you say that GBMC's even adult ED is unique with regards to to the smaller patients?
Yeah, absolutely. So at GBMC specifically, we see on the pediatric side, we see children from birth to the day they turn 18. 18 and over are seen on the adult ED side, which I don't think a lot of people realize. And also what's really unique to the Peds ED and the way that we work with our adult ED is that pediatricians actually see isolated head trauma, but any other injury that comes in, so lacerations, broken bones, motor vehicle accidents, the adult ED actually sees them because they're specifically trained from an emergency medicine standpoint to know the most about trauma and injury and that sort of thing. So they actually do us a great service by seeing children who come in who have injuries, who have burns, who have certain problems that are better taken care of from an emergency medicine standpoint.
Joining us today is Dr. Laura Scott, Chief of the Pediatric ED Inpatient Unit at GBMC. We talked about when parents should take their child to their primary care physician or their pediatrician, and when they should come see you. And now it's especially good to know all this because flu season's right around the corner, right? So parents are going to be looking at their kids saying, I think they have flu symptoms. I'm not sure they have flu symptoms. Yeah. I'm just going to take them straight to the Peds ED. Well, maybe that's not the best course of action. So let's talk a little bit about that as far as parents, especially with the flu season right around the corner. Yeah. How can they make the right decision?
I always remind families that it's so important to have a medical doctor who your child regularly sees, right? Whether it's a pediatrician, it's a family care doctor, it's a provider, it's a nurse practitioner, an advanced practitioner, so that you can call those people who know your child the best and say, hey, this is what's going on with Johnny. Do we need to come see you? Do we need to go to the ED? What should we do? So that should always be an option. And it's a great option because those are the people who know your child the best, right? We might only be seeing your child for the first time, and not that we can't get to know them, but it's really nice to have someone who knows your child be able to kind of give you guidance. They know you, they know him or her. And in terms of flu season, so flu season is here already. The first thing about that is I encourage everyone to get a flu shot and to talk to your pediatrician about when the best time to do that, depending on the age of your child, pediatrician or family care doctor. But flu season, so the things that really bring kids into the emergency department more than just going to their regular doctor in the office is going to be when they have trouble breathing, when they have a lot of distress, they're making weird breathing noises, they're breathing faster or harder than normal. Those are things that make us a little bit more nervous in the flu season. Flu itself with fever, maybe we're just not feeling so well, that doesn't necessarily mean come into the emergency department. But again, it's always a really good idea to call your regular primary care provider to talk through it with them to see if it would be better to go see them or to come through the emergency department.
So that's a perfect segue into my next question because you mentioned the word call. So can you offer some clues that a parent can use to decide when to call the pediatrician or family care physician or when to head down to the Peds emergency room?
Yeah, so I think parents have great intuition, right? I think many people know something's not right. The problem then is knowing, is this something that's not right? Is it enough to get me to the emergency department, or is it okay to wait until the pediatrician opens? So the first thing I would say about that is if you have any concerns about your child at all, that first call can really be to your primary care provider. If it's something that you know from that intuition is a little too much to just wait for your primary care provider or the office, then you can come on into the emergency department. I think, some specific things that we get questions about a lot about when to go which place. So the things that we see in the ER a lot that we need to see in the ED are any children who have trouble breathing, children who have seizures, children who just all of a sudden stop acting like their normal selves, kids with burns, with bad cuts, who fall from great heights, have concern for broken bones, kids who accidentally take medication that they shouldn't, or ingest anything else in the house that maybe might be harmful to them, kids with mental health concerns, things like that. Fever is a big one that we get, and you might be getting there, but fever is one that I think is very hard for people to decide. Should they see their regular doctor? Should they see us in the ED? And honestly, what I think is really helpful for people to know is that it's not necessarily the height of the fever. It's more about how the child is feeling otherwise. How long is the fever lasting? Are we drinking? Are we peeing? Are we acting like ourselves? And there are certain ages, 6 months and under, with fever that we don't mess around, and we like to see those kids in the emergency department. But fever is a big one, and I would always encourage people to call call their pediatrician or family care doctor provider if they have questions about the fever part.
Joining us today is Dr. Laura Scott, Chief of the Peds ED and Inpatient Unit at Greater Baltimore Medical Center. Dr. Scott, we actually have a question from our audience.
Okay, so is this on? Can you hear me?
Yeah.
Okay, I couldn't hear from here.
Yeah.
So we have kind of a twofold question from a member of our audience. He asks about peanut allergies. So I'm sure you guys see a lot of allergic reactions in the ED.
Yep.
So is there new research regarding the elimination or reduction of peanut allergies? And are there any devices other than EpiPens that have been approved?
Yeah, so it's a really good question. So for the first part of it, I think it was, is there new data about... Latest research. Okay, so in the last year or so, and don't quote me on that, maybe longer than that, more information has come out that earlier exposure to peanut-containing foods might actually be better to help children sort of to prevent them from having allergy down the road. So you guys might have heard of a specific product called Bomba, I believe. It's almost like a puff for kids to get when they're younger and first starting out on solids. And the idea is that you can sort of build up a tolerance, if you will, that might sort of help down the road to prevent that child from having an allergy. There's all sorts of data coming out all the time about peanut and tree nut allergy specific information because it's such a hot topic. So I can't say that I know exactly where we are. We do see a ton of peanut, tree nut, and other allergen exposures, kids who come in with serious reactions, which is also another reason to come to the emergency department. In terms of the second part of the question, are there things other than EpiPens? So there are different types of EpiPens, different brands. EpiPen and EpiPen Junior, it's actually a brand name, but there are other companies that make epinephrine-filled medicine to give. If at home, the first thing we always say if you're concerned your child might be having a reaction, actually if you have Benadryl in the house, liquid, or if they're old enough to take tabs, Benadryl is a good place to start. And also calling your pediatrician or calling 911 if you're concerned.
Okay. Yeah. Dr. Scott, we talked a little bit about when to take your child to primary care doc, pediatrician, and whether it comes to you. But I want to touch a little bit upon the relationship that you guys actually have with our GBMC pediatricians or our primary care docs that also see children. Why is this relationship vital for both parents and their children, and you guys as well as colleagues? Can you just talk about that for a little bit?
Absolutely. So I think it's very difficult to know where, just as why we're talking about it, right? If you need to take your child to your primary medical doctor or to the emergency department, and something that we started to do in the last year, so the last 8 to 12 months, was actually if we see children who present to the emergency room, we assess them quickly and think, okay, maybe this is not necessarily an emergent issue. There's definitely something going on. You definitely need to be seen, but you don't need to come through the emergency department to do it. And you either have a pediatrician at the GBMC Pediatric group or you have a provider at Family Care Associates on campus, then we'll actually reroute the family and the patient to go and see their primary care provider. And the beauty of that is that not only then does the family not have to spend time in the emergency department, which can be not fun, but also then they're rerouted to see someone who knows them, right? Who doesn't need to take the time to necessarily go through everything again because they know you best and can help sort out the problem that might not need emergent care but still needs to be seen. And it's been really nice to have that partnership on campus and be able to sort of really for the family's sake, it's so nice to be able to help reroute them and get them in a place where they might just be better served. And it's been a really nice collegial relationship that we've been able to form with the pediatric group and the family care group to make sure that we're all on the same page and doing what's best for the child.
And that's what's most important.
Yeah, absolutely.
Right. We got a question from one of our viewers, and they ask, can you tell us what to watch for with this quote-unquote polio-like illness, whether flu shots can help protect children from this? Is there any scientific evidence? Is there any science research?
So I'm not exactly sure what the question's asking about in terms of a polio-like illness. So there are a few different things. ADEM is one of them that you guys might have heard about, where the long and short of it is that basically very quickly children can sort of lose muscle tone, basically just become very limp. It's a very scary thing. It's not a very common thing. I haven't actually read any literature or seen anything that links it to getting vaccines, whether flu or not, and I don't believe there's any research about how if you get a flu vaccine it would prevent you from having this potential disease process later on. There's no real link that I've seen or heard or read about between the two things.
Okay. Again, joining us today on To Your Health is Dr. Laura Scott, Chief of the Pediatric ED and Inpatient Unit over at Greater Baltimore Medical Center. Dr. Scott, I'm going to run down a couple of health scenarios. Now, of course, every patient is different.
Sure.
So we're talking general here with no specific person in mind,
Right.
other than what I'm about ready to tell you. So
Got it.
I want you to tell me, in your in your professional opinion, what is the best thing to do?
Sure.
Okay, so here's one scenario. A baby is crying, or maybe not crying. So in your professional opinion, is that a valid reason to head to the Peds ED, or should they go see their pediatrician or family care provider?
So you're going to hear me harp on this a lot. It really depends on what else is going on with the baby, right? How old is the baby? If they're less than 3 months, it definitely makes us more concerned about if they're crying nonstop or not crying at all when normally they would be crying. Are they feeding? Are they urinating? Do they have a fever? Do they have any other medical problems? So you can see how complicated it is, right? Which is why it's so nice to have a primary care doctor who knows you, that you can call and say, hey, this is what's going on. And that person on the other end of the phone will absolutely say, you know what, you need to go to the emergency department if they think that that's true. So every kid is different, but I would say the important part of that question that you asked me is sort of figuring out how different is this from normal and what else is going on around it.
Okay. What about nausea and other gastrointestinal issues? Can you provide some clarity on when to head to the ER or call the pediatrician/family care provider?
Yeah, so for most nausea and vomiting or gastrointestinal illnesses, actually you could be seen by your primary care provider. The kids that we really want to see in the emergency departments are kids who really just can't tolerate drinking anything, right? Who can't keep anything down. But usually a general rule of thumb is if we're not urinating at least 3 times in a 24-hour period, that's when we start to get a little bit more concerned. So it's more about the hydration status, but for most things, for nausea, vomiting, you can actually just call into your primary care provider and they can guide you from there, and sometimes they can even prescribe medicine over the phone that might help to keep it at bay for a couple of days until your child feels well enough to drink.
During your last answer, you mentioned the dreaded F word. No, don't worry, it's okay. What you said was perfectly fine. That dreaded F word being fever.
Yeah, right.
So when it comes to fever, how high is too high, and when should a parent take a child to the Peds ED?
My favorite question. So I think that it is very fair that parents ask, what is the number that's too high, right? And I think many primary care providers feel the need to give a number, otherwise how will parents really know when to pull the trigger and come to the emergency department? In my opinion, in the way that our pediatricians sort of handle fever, is that there's really no number that makes us nervous unless you're 6 months and under, which I'll talk about in a second. Really, what we care much more about is how long has the fever been going on. 5 days or more tends to make us a little bit more nervous. Is your child drinking? Is your child urinating? What else is going on with your child? Fever itself actually is a great way for us to know that the body is responding appropriately to something that doesn't like something that's going on. So fever itself is not a bad thing. The times that we do give specific numbers out are for babies less than 3 months. So 3 months and younger, those are more vulnerable to serious bacterial infections. So any baby, especially babies under 30 days old, if they have a rectal temperature of 100.4 or higher, we should really be seeing them in the emergency department.
Okay. What should a parent do when their child has a persistent cough or wheezing, labored breathing? And I'll tell you, that croup thing is scary, right?
So scary, absolutely. So there are many different reasons that kids can make abnormal breathing noises. What John's talking about with croup can sound like a barky cough. If any of your children have ever had it, you know that it sounds terrible. It's very scary. The key there with breathing issues is that if you really feel like your child is in distress, can't catch their breath, breathing much faster, much harder than normal, you bring them in. We don't mess around with breathing stuff, right. Absolutely. So, if it's a little bit of a cough and your child seems otherwise fine, absolutely call your regular doctor. But if they're really having trouble with breathing, distress, especially you see them pulling in their ribs, in their neck, changing colors at all, you just call 911 or bring them on in.
All right.
Yep.
And this one last scenario, we talked about it a little bit, but I want to, again, get that message out there, because with kids playing lots of sports nowadays, and even doing recreational things like getting on a skateboard or on a bike and stuff, it happens. So with regards to head injuries, should parents automatically head to the Peds ED?
Yeah, so automatically, no, definitely not. I think it really, again, like all of pediatrics, it really depends on how your child is doing otherwise. We do worry a little bit more about younger children who fall from greater heights. We worry about vomiting that's persistent after a head injury. We worry about amnesia. We worry about just really being altered, so your child's not responding very well or appropriately to you the way they normally would in a couple of hours after the head injury. Those are all things that make us a little bit more concerned. I will tell you the majority of head injuries and concussions that we see in the emergency department probably don't need to come, which is should be a great relief to people that they don't need to come and wait and be seen. And again, it's something else that they can absolutely talk to their primary care provider about. And if that person's worried, they'll send them on in.
Right. You know, when my son was very young, you know, he had the croup, and you know, and unfortunately, we noticed that his fingernails, they were turning a little purple, which was even a bigger sign to try to bring him.
Absolutely.
The reason I'm saying this because I want to segue into my question in that we talked about the kids, right? But you guys also have to help the family members that are there as well.
Absolutely.
Tell us about the role that you guys have in the pediatric ED, as far as whether it's yourself or your nurses in working with those family members, because like you said, it's a very stressful time, especially with a head injury or croup or other conditions that they might come in.
Absolutely.
How important a role is it that not only you're addressing the patient, but also the family member or members as well?
Yeah, and I can't overstate the importance of actually forming a relationship not only with the child, but also with whoever the adults are, or family, or guardians, or support people who are bringing those children in. It's so important as pediatricians that what we do is make sure that everyone is comfortable with the plan, right? That everyone is comfortable with what we're doing, that everyone feels free to ask questions, that people know that it's okay to be afraid, that it's okay to be anxious, that it's okay to show your child your fear, these kinds of things. And these are things we do constantly every day with every child we see to try to make sure that everyone is comfortable, because if your child sees that you're uncomfortable, it's definitely going to make them more anxious. We, like I said, are so fortunate to have our child life specialists in the ED who are there 7 days a week now, which is awesome. And also just our pediatric staff, so our pediatric nurses, and everyone is trained to sort of not only take care of the child, but also to separate it out. If I'm taking care of the child, then child life can help take care of the family. But it's such an important piece of what we do, because we're not just treating the child, we're actually treating the entire family.
Joining us today on To Your Health is Dr. Laura Scott, Chief of the Peds ED and also Inpatient Unit at Greater Baltimore Medical Center. Doc, we got a few more minutes. So this is the time of the program where I like to get to the true or false questions. Okay, are you ready? They're tough questions, so here we go. Okay, our first question: when it comes to the emergency departments, all are the same with regards to treating kids and adults?
False.
Okay, why?
You know, I think that there are some EDs where you go and there aren't separated peds and adult sections, so I think everybody kind of gets grouped in together. Our adult ED colleagues are phenomenal, and they train to be able to take care of adults and kids. But what's even more important than that is the environment itself, right? The decor on the walls, the pediatric nursing staff knowing how to approach a kid, take their vitals, be able to do certain things. And so ours is really set up specifically to have that child in mind from the time they walk in to the time that they walk out. And not every emergency department is set up that way.
Yeah, which segues to my next question. A physician in a general ED will be able to treat my kid no matter how old they might be.
Yeah, so I think I said this earlier, but at GBMC, we actually, the day you turn 18, then you become a patient of the adult ED, actually. So we do that with a few nuances. If a pediatrician or a primary care provider calls a child in and they're over the age of 18 and asks us to see them, we gladly will. We also continue to see some children who have specific chronic medical conditions that they've had their entire lives, and they'd be better served on the pediatric ED side. So not every patient gets treated the same. We definitely take into account what's going on with them no matter their age. But in general, we see from birth to 18.
Okay, cool. And the last true or false question.
Yeah.
At GBMC, it is rare that our pediatrician and Peds ED doctors communicate with each other when it comes to our young patients.
Oh, false. Thankfully, this is false. We work so closely with our adult ED. I don't know how many people in the audience have actually needed to come to our ED, but the pediatric ED and the adult ED are right next to each other. Physicians have constant communication if we're concerned at all about an adolescent patient that we need the adult side to pick their brain about, and vice versa. We constantly see the adult physicians and PAs who take care of our trauma patients, of our injury patients who come over and take care of them on our side. We're constantly having communication with the nursing, the adult adult side triages our kids actually when they show up. So we've done a lot of education and work on both sides with adult nursing, with pediatric nursing, to make sure everyone's comfortable with peds. And one of the most important places that we really rely on our adult ED colleagues is when we have really serious emergencies where we need all hands on deck. And they never fail to help us when we really need them, which is awesome.
Dr. Scott, you're a plethora of information. One question I forgot to ask you is, why did you choose to become a Peds ED physician?
Yeah.
Oh.
Well, Peds is pretty great. So I love kids, and I think that it's fun for me to go to work every day. They're constantly saying something hilarious, or even when they're sick, they're trying really hard to be playful and funny. But I mean, I think there's just such a need for education, right? And I think I'm really drawn to kids, to families, to really just making the experience as comfortable as possible, which is what we try really hard to do in the PDD, and it gives me great opportunity every day to do that and to work on my communication. So that's why.
Awesome. And thank you for choosing GBMC and for being our chief of the Peds
Sure.
ED unit. That's all the time we have for our program for today. But if you have any questions that you would like answered, please submit them in the comments section of our Facebook page, and the fabulous Dr. Scott here will try to answer them as quickly as we can. The conversation on pediatric care at Greater Baltimore Medical Center continues with Mary Beth Marsden on Greater Living. Hi, Mary Beth. How are you?
Hey, great.
Everything going well?
Awesome.
It's good to see you as always. I see you're wearing the Ravens purple and black today. Very nice. Nice. Yes, nice touch. Before we exit today, I want to remind everybody, hey, if you're not doing anything this weekend, please come out to Legacy Chase. It's our annual event to help support oncology services and patient services at our Sandra and Malcolm Berman Cancer Institute at GBMC. We'd love to have everybody come out. If you need some information, go to legacychase.org. You'll find everything there, times of the steeple races, kids events, anything you want to know, you can go right there. Oh, look, there it is, legacychase.org right there. So please come on by, and we'd love to see you. It's supposed to be a beautiful day, and it's a lot of fun, and the money goes towards a great cause. So thank you. Dr. Scott, I want to thank you again for joining us. Cheers, and to your health.